means a lot to us, especially for all the participants that may be dealing with the topic of our webinar today about neurotrauma. As you know that head injury is our neurosurgical daily practice. So many doctors, many neurosurgeons, especially like in Indonesia or in India or other country, facing this problem of neurotrauma every day. So I'm glad that the topics of our webinar today is very important for us. And also I'm glad that there will be three distinguished speakers that will join with us today. I will introduce them. The first is Dr. Ahmad Faried. He is from Department of Neurosurgery in Bandung. And we already know that he
I think Dr. Asra have a problem in connection. So I will introduce the speaker. And the first speaker, Dr. Ahmad Faried, neurosurgeon from Bandung. Good evening, Dr. Faried. How are you today? Thank you so much. And the second speaker is Professor Iype Cherian from Nepal. Professor Iype Cherian, good evening, Professor. I hope that you will present it to us a very, very interesting topic for us, for all neurosurgeons in Indonesia. We are very glad with your presentation for this evening. And the third speaker is myself from Surabaya, and maybe I will give maybe a little about decompressive craniectomy. We are waiting for Dr. Asra as the moderator, but I think because Dr. Asra have a problem in the internet connection, maybe we will going to the first speaker with Dr. Ahmad Faried, neurosurgeon from Bandung. Dr. Ahmad Faried, for the time and place is your. Dr. Ahmad Faried can share yours PowerPoint,
Okay.
please.
Thank you very much. I will share my slide. Is that okay?
Yes, doctor, it's very okay. It's very clear.
Okay. Okay, thank you very much. And thank you very much for the invitation. And thank you, Prof. Cherian, for joining with us, because I'm sending my student to your place, and hopefully we will trying your method soon enough. Okay, so I'll just want to make a brief introduction about surgical management in severe traumatic brain injury, because most of the time we will deal with this situation. And in our country, we don't have the good database, but basically from Bandung data, this traumatic brain injury is still a leading cause of death and disability. We're dealing with mortality and morbidity. And at the end of the day, we will facing economical impact on this problem. And you can see all this number in trauma. It's increasing in Western Pacific and in Southeast Asia, comparing with Western country. And most of our procedure, almost 50%, still using our old technique to reducing the intracranial pressure. This is some of our data in Bandung. We work together with Johns Hopkins to tell everyone that we're facing problems in moderate and severe patient. And the recent data, we show that almost the recent data up to 2020, we have 11,000 cases, and it's always have problem in secondary brain injury. As you know, all these pathological mechanism of traumatic brain injury, and at the end of the day, we will facing intracranial tension, hypertension, and it will push us to think harder in how to deal with this kind of situation. And as this old doctrine from Alexander Monroe and George Kelly mentioned about how we will have some constant volume of the brain tissue, blood volume, and liquor. If there's something happen, if the disruption of this balance occurs, and the problem will come, which we know is increasing the pressure. And for surgical intervention of severe traumatic brain injury, we have to treat the intracranial elevation, which is the key of the successful of our treatment, and increases most of it because of the hemorrhage or the edema that causing its many way, hypoxia, for example, or hydrocephalus, and it will lead to herniation. And this is some types of our surgical intervention for controlling the ICP, decompressive craniectomy, cisternostomy that will presenting later on, or we also combining with external ventricular drainage. I'm not going into detail into the procedure as the next presenter will do. I just want to bring up an academic discussion in that somehow will affecting our privilege as a neurosurgeon. So I will start with decompressive craniectomy, and it's effective surgical procedure that we know for a long time, and it's have a two-step. Basically, we're removing the skull, bone, and opening the dura mater. And the most popular of this technique is hemicraniectomy in one side, or bifrontal craniectomy with we have to divide the valves. But their utilization is based on the topographical insult of the brain. It means usually we will see the main lesion of the brain. And this is some of the illustration about the hemicraniectomy and bifrontal craniectomy, which we use for a long time, and we still have the potential for this, and we will have some consensus later on. And this is some study about the procedure. But even in the model of the animal model of this disease is still controversial, and using the mathematical model, the decompressive craniectomy successfully reduced ICP, but it's the expense of the local anastomosis zone extremely, because of if we open it's too big or too small, it will have a problem, and the remain of the brain tissue will stretch because they will filling all that defect. And as the result of that stretching, it somehow will make dysfunction of our brain. but the use of decompressive remain uncertain. Somehow in Western area, and the comparison between low and middle income country will have some difference. Some clinical study, for example, in DECRA trial, revealed that it was effective reducing the pressure and make a short length of stay in ICU, but it not correlated with unfavorable outcome. So it's still controversial. And for another trial, rescue ICP, decompressive craniectomy resulted in lowering the moderate ICP, but the vegetative state, the morbidity or the severity will remain. And this is one of the recent consensus. Dr. Tedy involved in this consensus with Prof. Hafid, representing our as a low and middle income country. And the recommendation, go big or go home. You have to make a very large enough to make the edema is relaxing. But somehow, as we discuss later on, we'll see the detail on this consensus. And the second one is cisternostomy. So Professor Cherian introduced the concept in performing this technique in severe traumatic brain injury. And the procedure is basically opening the cistern that surrounding on the base of the brain and drainage the cistern, allowing the compartment is stay open in the atmospheric pressure. And you will hear about this in more detail after this. And the reasoning behind the cisternostomy is it's introducing the pivotal role of the Virchow-Robin species, which is much more larger in surrounding brain. But before this, it almost usually used for subarachnoid hemorrhage. And it's believed that if we can control this, it increasing the pressure in the basal cistern and lead or spare the brain swelling that will occur. But somehow it's very potential, but it takes time to mastering it because it's not easy to get into the swelling brain. Maybe Prof. Cherian will tell you and give tips about this in his presentation. And this is, if you see, is a very large vascular Virchow-Robin species in almost of the layer of our brain surface. And the history itself is not really introduced for trauma. It's usually used for acute aneurysm in the early of this recognition for cisternostomy. And there's some controversy about the technique or the indication, but it has a very good potential. But we have to learn more and we have to collect data, especially for proving by imaging data. And of course, it's need time to mastering, since only few center that focusing on this technique, and it's limited on that area. So if we have some interest, we can also developing in our center. And it's always the question about the outcome, the timing. We need to collect more data on this. So multi-center study will be very crucial And as I mentioned before, it's need time to mastering, need some experienced surgeon to perform this kind of intervention. And the population that have a beneficial on this cisternostomy, above all, is the subdural hematome that will make the brain is increasing in intracranial pressure, or some multiple cerebral contusion that have some refractory of the intracranial hypertension. So severe traumatic brain injury have a significant subarachnoid that can solve by this problem. And Prof. Cherian have some large study on this approach, comparing with only perform for craniectomy decompression or combination, and the result showed that better clinical outcome and lower mortality if we perform this cisternostomy alone. And for AVD, basically AVD, we just make some diversion from the swelling brain in the ventricle to bring the ventricular into the more space. But it's very old technique. Sometimes we combine the AVD with decompressive or with cisternostomy. And since the CSF approximately larger in ventricle and subarachnoid spaces, so if we can control this, we can have more space for the swelling brain. And as you see, the cistern is one part of our approach to make the intracranial pressure is decreasing. And from clinical studies showed that if we can perform AVD, we can control the hypertension. And still remain a controversy about how long we have to keep the AVD, and sometimes it will have some mechanical problem, like it will stuck or the clot will make the ventricle drain will not will have a problem on the diversion. And also the size of the ventricle itself are crucial for AVD if you use it in a very edema brain. And the conclusion from many study, the recommendation for decreasing the ICP, we have to focus on the old technique, but we have to open on the new approaches. And recent concept of the cisternostomy seem very potential to deal with brain swelling. And the potential benefit of reducing the vasospasm that occurs also will have to consider, like combination with decompressive craniectomy, cisternostomy with AVD. So I think that's a short, brief introduction and explaining about our intervention in neurosurgery. Thank you very much.
Okay, thank you, Dr. Faried, for your excellent presentation. And I'm sorry that I have lost my connection before, so I can get back again here. And I think the second presenter will be Professor Iype Cherian, that we already know that he was the one that introduced the concept of open cisternostomy in head injury case. So please, Iype, you have 30 minutes to present your presentation. Please, time is yours.
It's an honor, guys. It's
Yes.
an honor to be here. So let me just run through my presentation of Cisternostomy. So I've had a few fellows from the crowd who's been with me in my hospital, and they've seen how Cisternostomy works. And all I can say is to the young residents who are listening, it's time that we introduced micro-neurosurgery neurotrauma. It is time that we understood that cisternostomy, opening cisterns, doesn't only work in aneurysm surgery, it also works beautifully in trauma surgery. And the third thing I want to tell you today is all the bad habits, like taking up one side of the brain, being afraid of malignant brain swelling, so-called malignant brain swelling, all this starts from your resident days. And these things, they get ingrained in your brain. And another thing is, in the developing countries like ours, in fact, 5/6 of the world classify as LMIC, low and middle income countries. We have so much of trauma. We keep on doing a surgery which is 100 years old, and then we go to countries like Europe and United States to get a fellowship in skull base or vascular. And we stand there watching these surgeons do some delicate procedures under very costly microscopes, which it's difficult for us to emulate. Instead of that, start doing this skull base and vascular. Learn it from your seniors. Learn it from the guys who do your aneurysms. And be experts on vascular and skull base. After doing about 100 cisternostomies, you'll be able to clip any aneurysm. You'll be able to take any skull base, anterolateral skull base tumor. Believe me, I have gone that way, so I know. So this is a common scenario that you see all over the world. This is an acute subdural. And you see what happens? That's a consequence. And then you'll be thinking how to close. You're not even thinking how you can save the patient. Here, you're going to be thinking how you're going to close. I mean, saving the patient may be a distant dream now. Okay? What was the mistake? The mistake was that this guy did not learn how to open cisterns. And then, if this is a resident, this guy will have this fear for the rest of his life. He'll always think, oh, malignant brain swelling, malignant brain swelling. My story of discovery of cisternostomy is very simple. I will not go into the long story. I mistook a trauma surgery for an aneurysm surgery. Don't ask me now how. I've told this 100 times, but that's what happened. I thought the case that was in my friend was an aneurysm, which the angios of which I had seen before. And I went and operated it just like an aneurysm. The brain was angry. There was a lot of subarachnoid hemorrhage. The brain was swelling. So I went into the cisterns. I opened all the cisterns and the brain started becoming relaxed, but then I couldn't find the aneurysm. After 1 hour of searching for it, when I asked my assistant, he said he switched cases because the trauma patient had dilated pupils, so therefore he switched patients. So therefore, I operated on a trauma patient thinking it's an aneurysm, and that's why I discovered it. So if you want to do a cisternostomy, the only thing you need to do is, I'm not going to talk to you about technique. Think it's an aneurysm. It's an acom aneurysm. What are you going to do? Brain is swelling. What are you going to do? You're going to go into the base. You're going to go underneath the frontal lobe. And you're going to relax the brain by opening all the cisterns, putting a lot of water. That's exactly what you need to do. Right, let's see this case. One of our first cases. See, the cisterns are not visible at all. Okay. And this is a 23-year-old male, left pupil dilated. Okay. Severe edema. And you see, this was the time when we were putting in a very thin patch of bone. You can see the thin patch in this cut and that cut. See, the thin patch of bone, you know, most of the temporal lobe we used to bite out. You see, the difference here is that the cisterns are open. All the cisterns are open. Compared to the previous scan, the difference here is that the cisterns are open. Even the contusions are not taken. You will notice that even the contusions are not taken. But you see this guy now. Okay, it's one of my old patients, right? Walking, talking. As soon as the sutures are out, this guy is okay. Another one. Okay, pretty bad. I mean, I'm sure you'll do a decompressive for this one. See the temporal contusion. Bone kept back, small extradural, no problem. Patient comes walking. Another one. See the midline shift here. See the CP angle system is already herniating. Okay. See the post-op. Cisternostomy. This is the guy. Another one. GCS 15 by 15, residual cranial palsy. We didn't even touch the burst lobe. Okay. We didn't even touch the burst. We just did the cisternostomy, and that's about it. Another one, very bad. No cisterns seen. Left pupil dilated, GCS 6 by 15, subdural and burst lobe. This is post-op. Another one, can you see there are Durett's hemorrhages here? You see the midbrain here. You see the Durett's hemorrhages. Okay, it's pretty bad, really bad. And this lady, bilateral fixed dilated pupil. Few of our cases have this. So we, you know, you can see that, and this is the injury that we produced because this brain was so. I'll show you the video of this one. Okay, you will see the video of this one. You see how the brain was coming out. You'll see that. This is the patient. Okay, this is the patient still with the left third. I mean the right third nerve palsy. Okay. Another one. You can see the torsion of the brainstem. Sorry. You can see the torsion of the brainstem here. Okay, very bad. Burst lobe. Cisternostomy. This is the guy. Another one. You see this one. Burst lobe, subdural, frontal injury, subarachnoid hemorrhage, everything. Midline shift, everything. Okay. This is quite recent, performed by one of my junior consultants. That's cisternostomy, and that's how she is in my office. Okay, before she goes home. That's another one, acute subdural, like the one you saw, the first picture that I showed, acute subdural, and that's it. No decompressive, just cisternostomy, drain into the prepondine cistern, and out. Another one, same result. And these patients are walking back. Otherwise, if the GCS is very low, they come to at least a meaningful life. That's the difference that you have to understand. These are patients who are, if you do a decompressive, they're going to be in coma or they're going to be a vegetable for the rest of your life. And I'm not showing you mild cases here. Okay, I'm showing you pretty bad cases. So you can see before the dural opening, after the subdural is taken out, and that's how the brain slacks, and that's the catheter coming out. These are all from the rest of the world. This is from Czech Republic. Skin to skin injury did it in 65 minutes, and ICP dropped from 48 to 11. Another subdural from another center. See that? Another one. So I'll keep on showing you. So this is one of my consultants. Another one, subdural. Okay. And that's a video. These are all my boys. I mean, they are people trained by, Ido was here for some time, so Ido will know my junior consultants. These guys got trained with us, Cisternostomy. Now they are good at exposing, pretty good at exposing the basilar, and see, you can see the basilar there, PCP and the basilar. Okay, so you see such a tense brain, and you can see the PCP and the basilar there. What is the surgical technique? Nothing, just treat it as an aneurysm. And that's how the closure is. So brain is so lax. The brain which is so tense has become so lax. This is CSF shift edema. What is CSF shift edema? It's very, very simple. You know, the CSF outside, it goes into the perivascular spaces around the vessel. And that's what produces the cooling. And this is now well known. This is what produces the cooling. And in the night, this pathway also opens up to the ISF through aquaporin 4 related gates, aquaporin 4 controlled gates. It goes into the ISF also, that is cleaning. So that's a separate pathway that happens only in the night. But cooling is all the time. Cooling doesn't go to the ISF, but it will remain in the perivascular spaces, which are extensive. Massive amount of perivascular spaces. You won't believe how much is the volume of this, because every vessel that goes into the brain has perivascular space around it. So what happens in trauma? There is subarachnoid hemorrhage that raises the pressure within this system, because bleeding always comes at high pressure. So what happens to the CSF? The CSF is under high pressure. Because the CSF is under high pressure, what happens to it? Gets driven into the perivascular spaces, And therefore, because thousands and millions of perivascular spaces all over, they get dilated by this cisternal CSF, and that's why the brain starts swelling. And that's exactly why in a CT scan, you will not find any cisterns, and you will find the brain swollen. It's common sense. I mean, if you ask other people, they tell that, oh, the CSF went into the spinal, the spinal region and all that. It will never happen like that, because if it had gone to the spinal region, the chap who started, Decompressive would have never done that, because, he said, who started Decompressive? 102 years back, somebody started Decompressive. And this man said, if there are signs of raised intracranial pressure and the CSF pressure is not elevated, you know what he did? He did a lumbar puncture. And the lumbar puncture pressures were normal. And there were signs of raised ICP. So if the CSF went into the spinal canal, definitely the CSF pressure would have been elevated. So decompressive hemicraniectomy was started on a wrong premises, wrong theory. I mean, and it has survived for 100+ years, because it's a winning solution for senior surgeons who doesn't have to come at 2 a.m. in the night and sit on trauma. It's a winning solution for junior neurosurgeons who wants to play around with the brain, and nobody wants any guarantees. Anywhere in the world, trauma means no guarantee. Okay, Princess Diana didn't have a guarantee, so you cannot ask for a guarantee. So you can play around with it. If you cannot close it, you stand on it, you cut off half the brain. No problem, because nobody's asking for anything. It's not like aneurysm surgery, where you can't do all that with aneurysm surgery. So it's a win-win solution for the senior consultants, for the juniors, and of course for the companies, because every single surgery, every single major center in every major city does about 4 or 5 of these every day. In India, China, Indonesia, Malaysia, South America, Africa. This is the biggest business. Cranioplasty plates are manufactured by Johnson & Johnson. I'm naming them because I need to name them. It's only right that the young understand what's going on, because I've been fighting against this for a decade plus. So Johnson & Johnson and some other companies manufacture the titanium plates as well as now there are custom-made plates, you know. There are custom-made plates, there are titanium plates, the bone cement, everything is manufactured by Deep Synthes, all this brand is of Johnson & Johnson. And who sponsors the most trauma meetings and the trauma journals? Johnson & Johnson, right? So it's a win-win situation for everybody. Who's losing? Patients, okay? They're going to lie down with half their head sunken in coma, and instead of doing, an acute subdural, if we knew enough microsurgery to take out that subdural, we could have done that and this patient would have walked back home. Instead of that, we're creating a vegetable. So it's time for us to ask whether we should introduce microneurosurgery to trauma. It was introduced to aneurysm surgery, it was introduced to skull-base surgery, it was introduced to spine surgery, it was introduced to every single surgery, except trauma surgery, which is the greatest load for us. Whether it is time for our residents to learn microneurosurgery for trauma, whether it's time for us to put microscope in the trauma theater instead of saying that, oh, it's trauma theater, we don't have a microscope. We have a microscope for aneurysms, but we don't have a microscope for trauma. How bad is that? So that is the experimental model which proved CSF shift edema. That is Calgary. And you could see the T2 weighted hyperintensities, which showed that there was a lot of fluid shift. Our theory was that the subarachnoid spaces were full of blood and the brain was full of fluid, exactly what it was. So we did histopathological findings of the sacrifice and exactly what it was. So CSF shift theory was proven proven in basic sciences by the Garnett's group in Calgary. And somebody asked me, why is EVD different? Because EVD doesn't, the ventricles doesn't communicate with the brain.
She does so along very specific.
The ventricles doesn't communicate the brain. So,
Actually does
I'm
so
sorry, this iPad is acting on its own. Okay, right. So if you inject intracisternal, this is what happens. All the markers go into the brain. Inject into the ventricle, this is what happens. Nothing goes into the brain. That's because the ventricular walls and the parenchyma doesn't communicate. So when you're taking CSF out of the brain, you're just playing with the compliance of the brain. That's all you're playing with. But you're taking CSF out of the cisterns, these two compartments, that is the brain and the CSF, acts like one. So therefore, the brain relaxes. Okay, that's what Iype is talking about.
Actually does so along very specific anatomical structures. There's a specialized anatomy that allows the CSF to move very quickly and very deep into the brain, exchanging with the fluid that's inside the brain and then moving out. So it's a much more efficient system.
So that's what happens. So you have cisternal blood, CSF goes in. So we open the cisterns and that CSF comes out. It's called the reversal of CSF shift edema. And if an edematous brain, if you open decompressive, that's what happens. You're herniating, instead of herniating, transtentorial herniation and the patient dying, the whole brain herniates out through this and produces a vegetable. You're converting a cemetery into a vegetable market. So these are some of the ways to get into the base. These are all advanced techniques. These are orbitomeningeal band and transcavernous. This is all not needed. Okay. Earlier I used to show these videos, but I can tell you, how many of you are doing aneurysms? Just imagine it's a bad grade aneurysm and don't do much skull-based work. Bite the sphenoid ridge off, get into the base of the brain, open the opticocarotid cistern, pour water, open the lateral carotid cistern, pour water, and through the lateral carotid or the opticocarotid cistern, just Open the membrane of iliac crest, just put in a little bit of fluid, and then you're done. Okay, so that's it. That is how you do cisternostomy. There's nothing for you to worry about. Okay, don't think it is a separate technique or something. All right, it's not a separate technique. So let's show you some very bad cisternostomies from my earlier days, so that this is what you're going to face. Okay, this is what you're going to face. Very bad brain, really tough. Okay, people ask me, I've gone to the base of the brain. I've not done much skull base work. Okay, just sphenoid ridge, biting and just opening into the base. See, you see how the brain is coming out. Okay, but that's frontal lobe. That's all right. Believe me, that's all right. It's a leap of faith, but it's all right. So frontal lobe, a little bit of frontal lobe sacrifice is better than the patient dying and the patient become a vegetable. Believe me, you remove that entire frontal lobe, the patient is going to be functionally okay, or maybe he might lose a bit of frontal lobe. He must be a bit frontal lobish, but that's a small price to pay, rather than a patient lying down, completely in coma for the rest of his lives. I mean, these kind of brains, you see the kind of pressure that I have to exert sometimes, but believe me, don't get into the cisterns and then exert that pressure, because you tear the vessels. But if you are on top and if you're not able to get into the cisterns, don't worry about this. I wanted to show you this because this is what you're going to face. This is exactly what you're going to face. Okay, so these kind of brains, there are easy cisternostomies. It's an acute subdural. You take an acute subdural and then there is a lot of space. Okay, then you can open cisterns without much problem and be elegant, just like an aneurysm surgery. But these diffuse axonal injuries, burst lobes, severe, very bad cases with pupils dilated, this is not going to be easy. Okay, that's why I want to show you. And this is 5 years before video. Okay, I want to show you this because I don't want you to see elegant, very elegant surgeries and think that, oh, this is easy. This is, and then suddenly you start facing this, then you'll think, oh my God, I mean, this is crazy. This is crazy. Okay, it definitely is crazy. And you can do this. You can do any ruptured aneurysm. Okay, that's the optic nerve and that's a carotid there already. Okay. Can you hear me?
Yes, Professor.
Yes.
Can you hear
We
me,
can.
all of you?
Yes,
Yes, we can.
hear you.
Hello? Can you hear me?
Yes,
Yes.
we can hear you.
Yes, Professor. Loud and clear.
Continue. Iype.
Yeah. Yeah, so I was just showing you some videos. I mean, sorry, I wanted to show that video and I will stop with it, I think, because I don't know whether I'll be able to, I'm not able to, forward it. So let's see it once more. You're going to see that I have gone into the base reasonably. I've not done anterior craniectomy. I've not done anything. I've just taken off the entire sphenoid ridge. And I'm going to open in the base, unlike a DZ. Okay. And you see how bad that brain is. Okay. It's just coming out on me. Okay. But what I'm going to do, okay, I'm going to put in patties after patties and get into the base, because once I do that, once I see the optic nerve and the carotid, things are going to be under control. It's a leap of faith, believe me. Okay, it's very inelegant at times. That's why I wanted to show you this kind of surgeries. I didn't want to show you transcavernous dissection, and I didn't want people clapping, saying that, oh, it's a beautiful surgery. This is not a beautiful surgery. But you see the size of the brain, size of the opening. It's hardly 2.5 centimeters. in such a tight brain. I've opened 2.5 centimeters. I'm going to the base of the brain, and just like a suprabrow clipping for a ruptured ACOM, very, very bad grade ruptured ACOM. Imagine it's a very, very bad grade ruptured ACOM, suprabrow clipping. Okay, usually you won't do that, but that is how this is right now. Because if I open this brain's going to be on my face. The entire brain's going to be on my face. So I'd rather that I get into the cisterns first. Okay, get into the cisterns first, and you need a lot of courage and confidence and expertise. Exactly what you need during your residency. Okay, and you should need somebody to guide you. So that's already your optic nerve and your carotid, and then you put your microscope in and zoom in, irrigate. I'm not going to coagulate at all. No coagulation. Okay. Once you get into this, the bleeding automatically will stop. I'm telling you, the bleeding will stop. Okay. You can see the patties there, and open between the optic and the carotid. Okay. Suction at very, very low suction. Suction should be literally very, very low. There's a lot of perforators there. Okay. And you're already seeing the basilar. That's the basilar. Okay. It took 5 minutes for me. 5 minutes to get into the basilar. Okay. In such a tight brain, if you have imagine if you have a ruptured basilar and it's very bad, 5 minutes you're into the basilar. Okay, 5 minutes. And then you start cleaning up again, right? All the bleeding you control by putting these at different corners. Okay, just like what you will, and see the brain pulsating. See the brain pulsating. Okay, beautifully pulsating. Now we can open. Okay, now we can open and go in, and you will see this brain now. You will see the damage that this brain has. Okay, once it starts pulsating, it's safe for you to open large and then complete your cisternostomy. Take out your tube and then go in and then open. And it's a stage by stage procedure. First step is to get into the cisterns. Once you get into the cisterns, things are easier. Okay, and once you do that, you can see the optic nerve clearly now. Okay, define the optic nerve clearly and define the carotid clearly, lateral carotid clearly. And once you do that, once the brain is a bit lax, then you can go ahead and open. But if you open without, like you do in a decompressive, if you open without getting into the cisterns, you've already seen the basilar, you're irrigating out all the blood, sucking out all the blood, you're not bipolaring anything. Okay, so just keep on irrigating, suction, and okay, you've gone in the second time. Now you open the brain. Okay, another one, you open, you see that the brain is severely damaged. You can see the CSF collecting there, keeping on collecting. That's why I say, you take off the CSF, it will keep on collecting. Okay, this is the CSF shift edema reversing. Okay, you will see this brain, and this brain is covered by patties. Believe me, this brain, and you can see the basilar, you can see the optic nerve. This brain is so injured, believe me, that's a basilar artery. Okay, that's a basilar artery. Between the opticocarotid window, that's a basilar artery. Okay, but membrane of iliac crest is cut completely, and this brain is lax. Okay, this brain is lax, and you put a catheter into the opticocarotid space, and you come out and you see this brain burst lobe everywhere. And you can see how lax is this brain. And this patient, believe me, instead of doing a decompressive, this patient will do much better. And another diffuse brain swelling. Okay, I'm going to show you this because I want you to see all these bad cases and understand this is what you're going to face. Seniors and juniors, this is what you're going to face. Do it. Believe me, you'll be happier, your patients will be happier. Shirk from it and keep on doing decompressive. You will have a lot of, you can say, yeah, decompressive helps and it is easier, doesn't need any infrastructure. You see, that's diffuse brain swelling, okay? And see at the end of it, okay, that frontal lobe, 2.5 centimeter opening, that frontal lobe is completely lax now, okay? And that's it. You really don't need to, because this is diffuse brain swelling, there's no subdural. So you don't need to even open, okay? Right. These are the cisternostomy indication scores. This is a very important finding. So cisternostomy is a proactive surgery. You don't wait for the medical management to fail completely and the patient is almost dead and then take up the patient. That's stupidity. Okay? So you don't want to wait. And there are many scores that will help you. And one of the main things is this ipsilateral dilated CP angle. And if you have a dilated CP angle system, you should take up the patient immediately. These are all studies which are published all over. We have so many studies right now. You can read up the literature from all over the world, from Brazil, from India, from China, from Switzerland, from Italy, from literally from everywhere we have a and these are all papers. You know what is the latest critique from the WFNS president, Angelos, and the Cambridge group? They say that it's a very good technique, but it can be done only by a very trained neurosurgeon. Is that an excuse? We better train ourselves. We cannot say that, oh, aneurysm can only be done by trained surgeons, so let's do decompressive. Skull-based tumors can be only done by very trained surgeons. So here, residents are doing skull-based tumors, so let's just do decompressive. Is that acceptable? I don't think that is. So we better train our residents to open cisterns in tight brains. It requires, definitely it requires training, but as with everything, with a little bit of stress and a little bit of training, the results are much better. Okay, so Genos has accepted cisternostomy as one of the treating choices, and the online registry and multicenter trial from United States with Shabarish Natarajan is coming right now. And well, we will not talk today about the brain cooling and cleaning, but it's a very interesting thing that we found out later on. And we, this theory is now accepted worldwide, and it's been accepted in the Physics of Mind and Brain Disorders. It's a Springer neuro textbook. It's all from our theory of cisternostomy that this journey started. Thank you very much, guys. And I'll stop sharing now, I guess.
Okay, thank you very much, Iype, for your very valuable and nice presentation. I think it means a lot to us, especially for young neurosurgeon and all resident in Indonesia. Okay, there will be question and answer after the third speaker. And the last speaker will be Dr. Tedy Apriawan, and he will talk about the decompressive craniectomy, how the recent guideline about this procedure in neurotrauma. Please, Dr. Tedy, you have 20 minutes, and then we move to question and answer. Please.
Thank you, Dr. Thank you, Dr. Asra. Good evening, everybody. So tonight I want to share about the decompressive craniectomy recent guideline, a purpose for hospital with neurotrauma surgery in facility. So there is something that I want to share about study in the decompressive craniectomy for these 5 years. And maybe this is the one journal from China that we can see in here. I'm sorry. That we can see here that there is a decompressive craniectomy in epidural hematoma, and post-traumatic after that, there is a massive cerebral infection. With the patient is, the number is 100, sample is 176 patient, and for post-traumatic MCI was diagnosed in 32. But the performance of the decompressive craniectomy simultaneously with the initial hematome evacuation surgery improved their functional outcome compared with the delay surgery. We will talk about the primary decompressive craniectomy, and we will talk about the secondary craniectomy late or early. As you can see in here from the journal, we can see, maybe we focus in the case number 3. We can see in here there is an epidural hematome pre-operation. After the operator make a decompressive craniectomy, we can see in here the onset of MCI, the cerebral infarction in the occipital lobe. Then there is a midline shift and mass effect. If we see in the DWI, MRI, we can see there is hyperintense in the occipital and in the parietal temporal lobe in the left side. In the 10 days after that, we can see in here the edema cerebri is better and the midline shift is better. But in 3 months after that, we can see in here there is a ventriculomegaly, maybe because there is a fibrosis or encephalomalacia, we don't know. But we can see in here that the mass effect and the midline shift is better before the previous one. So what will you do, the young neurosurgeon? Maybe this is, I want to give this all experience for the young neurosurgeon. What will you do if you get this patient below? Like the patient in here, you can see that the patient is fall. At 7:45, you can see the patient is fall from 3. We can see in here, in 9:45 in the morning, the patient is bring to the private hospital with the KCS is full 15. KCS is full 15 with pupil equal. And you can see in the picture, we have an epidural hematome in the left side. At 10:30, the KCS is decreased, 3, 4, 6. Total is 13. After that, the operator make a decision to perform emergency craniotomy for evacuation epidural hematome. But in our country, Indonesia, there is a problem. Always family will discuss because we have a different belief in culture, different beliefs in religion. Maybe the economic now is very different from the other country. The family discussion long enough, very long enough. After that, the family the family make a decision to bring to another center because they want to use the government insurance. In 14:45, the patient arrived to our referral hospital, another hospital, with KCS is critical, 112, total E4, with pupil unequal. You can see in here, there is a progress. The epidural hematome is bigger. And we can see in here, there is a lot of, we can see here, there is a diffuse brain injury with very, very massive effect. Midline shift is above 1.5 centimeter. Then in that hospital, the patient is make we decide to make a emergency operation for craniotomy evacuation of epidural hematome and early decompressive craniectomy. You can see in here for the CT scan control, there is a big image of hypodense. This is I think this is a picture of the infarct cerebri. So, and we put ICP monitor. The patient is survived, but for the 6 months after follow-up, the patient have a disability, very, very bad disability. So let's answer this question. This is usually common in Indonesia. This question is very common. The first one is, do the common practice for early decompressive craniectomy increase the patient survival? We don't know yet. Do the common practice of early decompressive craniectomy increase the rate of morbidity and incapacity for the patient? do we need decompressive craniectomy in our center when we do it, early or late? In what case that we need to perform decompressive craniectomy? This is always common question for operator neurosurgeon for emergency case in traumatic brain injury. The principle is the beneficial effect of decompressive craniectomy in the treatment of severe traumatic brain injury is still controversial. But there is no debate that decompression should be performed. So we all know that decompressive craniectomy is a neurosurgical procedure of the skull to allow the swelling, the brain room to expand without being squeezed. And Zhang in 2016 include that there is a ultra early decompressive craniectomy below 4 hours, early decompressive craniectomy below 24 hours, late decompressive craniectomy after 24 hours. There is another categories. There is a primary and there is a secondary. Primary is done at the time of the mass lesion evacuation. For the secondary craniectomy, done to treat the refractory ICP. When we see this journal, we will talk about the DECRA, we will talk about the rescue ICP or STITCH. I will explain later. Sorry. So for the decompressive craniectomy, there is I read some journal from claimants. There is a unilateral DC, usually indicated in the patient with unilateral hemispheric swelling or bilateral decompressive craniectomy, may be performed or indication in the patient with diffuse brain edema. In the left side, it is a unilateral decompressive craniectomy, and the right side is a bifrontal craniectomy. How about the size? The size that Pablo and Carolina Campbell in 2015 said that minimum is 12 centimeter diameter. So because there is a lot of journal and in these 10 years, many neurosurgeons will comment and question related in decompressive craniectomy, always pessimistic. We don't know if decompressive is work. If it does work, we don't know what for which point. Was the aggressive treatment effective? Is the intensity in the treatment proportional with outcome? What is the long-term result? How is the quality of life? The procedure remains controversial, and there continue to be uncertain regarding its appropriate application. When we do it, early or late? So our experience in our center in Soetomo Hospital is Java, Surabaya. Professor Hafid, Dr. Joni, Dr. Asra, and our department try to make a decompressive craniectomy for critical Glasgow coma scale in severe traumatic brain injury. Critical is mean that the patient with KCS below 5 and below. And we want to know how about the conclusion that we perform decompressive craniectomy in critical Glasgow coma scale. So we can see in here that the result is from 37 patients with critical KCS below and 5, 13 is survived and discharged from hospital, only 35%. But the problem is for Indonesian patient, 2 patients is died during the follow-up, 2 patients is reject to contact. Maybe they change the address or change the phone number, and because of the culture, sometimes they reject our phone. After that, we only have 9 dead alive and could be observed. From that 9, you can see in here, not good for the extended Glasgow outcome scale. Lower good recovery, 2. Lower moderate disability, 2. Upper moderate disability, 2. Upper lower severe disability, 3. So I think the result is not good enough because the patient have a disability and the number of mortality is very high. If you can see, there is a lot of journal for these 10 years. I think all neurosurgeons in Indonesia will read different journal and make different pattern and make different management. I think there is no debate about that. This is It is about how we perform decompressive craniectomy management in our areas. It depends on the operator. So I will, we have to still remember about the DECRA, the rescue ICP, and STITS. If you know the DECRA, the aim of study is for early decompressive craniectomy, and the rescue ICP is for the less, usually for late decompressive craniectomy or secondary craniectomy. And you can see here the number of patients is for DECRA is 155, and for rescue ICP is 398. For DECRA, the type of surgery is bilateral craniectomy, and for the rescue ICP, bilateral or unilateral. I will not mention about states. And the result for the DECRA and the ICP is, this is the first one, have generated debate among clinicians and researchers working in the field of TBI worldwide. And it was felt necessary to provide general guidance on the use of DC or decompressive craniectomy following TBI and identify areas of ongoing uncertainty via consensus-based approach. So we need a consensus-based approach. And these two trials were internationally distinct clinical questions. The result of both trials were eagerly anticipated, and following publication sparked further debate in the TBI community worldwide. So at the time, thank you for Professor Hasan and Dr. Angelus Kolias that invite Indonesia to the Cambridge University, and thank you for Professor Servade at that time, Professor Hafid, and we delegation from Indonesia can attend the first international consensus meeting on the role of decompressive craniectomy in the management of traumatic brain injury. I think this is important for neurosurgeon in Indonesia because this is a consensus from 50 delegates in all countries. 50 countries from all over the world came to one place in Cambridge to make some consensus about decompressive craniectomy. On the first day, the delegates work in the 6 small group, and we make identifying area, agreement, disagreement, and make a 10 recommendation for clinical practice and area. The second day, all delegates or all the small group presented their problems to make a small discussion and propose recommendation. And the next day, we make an anonymous real-time voting. We make a real-time voting at that time to propose recommendation for all participants and all delegates in 50 countries, and the result will be accepted if the percentage is above 70. We have 6 at the time themes. The first one is primary DC for mass lesion. The second one is secondary DC. The third one is perioperative case. The fourth one is surgical technique. The 5th is cranial reconstruction. The 6th one is decompressive craniectomy in low and middle income country. Maybe Indonesia now for the salary is the position Indonesia is the middle income country. This is very important for the number 6. Number 5 I will not discuss, but let's try to discuss maybe a little one for neurosurgeon Indonesia. What should we choose in decompressive craniectomy? The first one we can see in here. Please mention the red line and the yellow circle. The first one, if the brain is bulging, consider to leaving the bone flap out. From 49 countries, 49 agree 100%. One country is didn't take real-time voting, is okay, but 100 is agree, is very, very good result. The second one, if the brain is very relaxed, you can see in here, if there is a high-risk progressive brain swelling, is not keeping with high-risk progressive swelling, the bone flap should be replaced. You can see in here 43 agree, but the other country no, 87.8%. Please remember that even if 6 countries didn't agree, 6 countries will represent a lot of neurosurgeons in their country. This is will make another journal to make a debatable and spark again. The third one, this is very important. The surgeon judgment must be used to decide whether they leave the bone flap out or not. 47 for 48 and 97.9% agree. After evacuating the isolated epidural hematome, the bone flap in general should be replaced. This is only 88%. This is for me. I choose replace at that time because yes, in my center, epidural hematome always we put the bone back, but we know that a lot of neurosurgeons still sometimes they to leave the flap bone out. It's okay, but I will explain why this consensus is very important. In the primary decompressive number 5, in the primary decompressive craniectomy, the size at least 12 centimeter until 15 centimeter. 94% agree. Number 6, decompressive craniectomy is an option for patients with contusion, in whom contusion are not evacuated. Only 83.3%. Contusion is very small. Sometimes there is a center still try to put back, but sometimes and there is a center try to make a decompressive craniectomy. So the number of presentation is very decreased to 83.3%. Number 8, when the bone is replaced, an ICP monitor should be placed. This is very low, only 74.5%. Why? Because not every center have an ICP monitor. There is a country at that time said to us that they didn't have any ICP monitor. That's why only 35% agree about ICP monitor. An ICP monitor should be placed following primary decompressive craniectomy if available. 77.1%. In the situation where there is no ICP monitor, CT scan should be used to monitor the progress. Yes, 97.9%. 47 countries agree from 48. And for now, we change to the secondary decompressive craniectomy. Secondary, which usually is performed after we try to make a ICP control in the ICU sometime. The first one we can see where available, ICP monitor is needed as a component of decision making the secondary decompressive craniectomy. Yes, everybody is a lot of the country is agree, 95.7%. The number 3 is very important too. The optimal candidate for the secondary decompressive craniectomy is a patient whose ICP is elevated. And I think everybody agree, 97.9%. Where available ICP monitoring should be used in conjunction with CT finding and neurological exam to decide on the secondary decompression. Yes, not only the ICP monitor, but we must to try to look the CT finding. We must to try to see the neurological clinical at the time. So after that, we can decide the secondary decompressive craniectomy. Yes, 97.9 country agree. The number 7, we can see in here that DC may be decrease the mortality. However, is not a benign and associated with potential complication and associated with potential increased risk of disability. It is same with my case before, and 93.8% country agree. Before contemplating the secondary decompressive craniectomy, conduct frank discuss with family. Yes, because we have to know What happened after that regarding the risk, benefit, alternative, and potential prognosis? 97.9% country agree. Number 8, ICP monitor should continue after the secondary decompressive craniectomy. This is only 76.6 because, yes, the reason is there is a country that didn't have ICP monitor tools. The number 9, recommended large decompressive craniectomy with durotomy to effective reduce ICP. Yes, reduce ICP. Yes, this is true. 91.5% agree. Bifrontal or unilateral decompressive craniectomy are the option in the surgical treatment of diffuse TBI. Yes, 95.6% country agree. For the perioperative care, I will not discuss for maybe number 5. Number 4 is very important. Maintaining the ICP therapy during surgery and immediately post decompressive craniectomy unless limiting side effect. So we must still give the therapy even we have performed the decompressive craniectomy. If ICP is not controlled, then number 6, this is a problem that we usually have in our center. If ICP is not controlled by DC, decompressive craniectomy, what we have to do? The first one, continue therapy is if there is no change in self-viability as assessed by pupil, clinical stage, and CT head image. 93.5% agree. Find the reversible reason for the intracranial hypertension. We can check the GSF drainage disorder, maybe we can check the EEG, or maybe check the extracranial reason. Then consider to brief sedation, hold to access the neurobiological exam, accepting mild intracranial hypertension. 91.5% agree. For the surgical technique, I think all the young neurosurgeons know that the number 2, the bone flap size should be large and incorporate removal of bone to temporal fossa floor, both unilateral and bilateral decompressive craniectomy. 94% country agree, 47 from 50. The dura should be open and parameal dural closure should not be performed, 98%. Expansile dura graft should be used, 91.5%. Number 6, avoid the technique that will contribute to secondary injury. Example is maybe migration of the dural graft material, excessive graft, or maybe hemostatic material volume. I will not discuss about cranioplasty this in another discussion. This is the important one because Indonesia in the position of middle income country. So the result of the DECRA and the ratio ICP are not generalizable to condition in LMIC. This is 84% agree because not all country like low and middle income country have a tools that advance enough to make some rescue ICP or DECRA. Number 2, we recognize and support that decision about DC must be made in context of the local knowledge of access to medical resource, capacity for long-term care, and cultural belief. This is maybe the best one in Indonesian country. Why? Because every city in Indonesia, every neurosurgeon in different city have their local knowledge because of the medical resource. In Surabaya is different with Bandung, Bandung is different with Jakarta, Jakarta is different with Medan. But we have protocol from textbook or the other. Still, the context of the local knowledge is still maybe sometimes still different. The number 3 is we recognize that the most of the decompressive craniectomy in LMIC are primary DC. This is what we perform now. So in our center, even now, we still make a primary DC. We know that, and we still perform this. The number 4, decision to perform decompressive craniectomy should be made by attending neurosurgeon if possible. This is all should be made by the neurosurgeon that responsible at that time. So all of the decision is from the neurosurgeon who take that duty in that day. This is decision and 90% is agree. So for the take-home message is the first one, for decompressive craniectomy, the bone flap should be large size. The surgeon judgment must be used to decide whether to lift the bone flap out or not. If available, ICP monitor should be placed when replace the bone. ICP monitor is needed as component of decision making of secondary decompressive craniectomy. You need good neurosurgical intensive care. The large DC with neurotomy to effectively reduce ICP, expansile dural graft should be used. Decision about DC must be made. I make a red. This is I use a red bold. Decision about DC must be made in the context of the local knowledge of access to medical resource, capacity for the long term, and culture belief. I think that's presentation that I can give. Thank you so much for the time. I think I will give back to the Dr. Asra. Thank you so much.
Okay, thank you, Dr. Tedy. Thank you for the three speakers. And then now we move to question and answer. And there are many questions for all the speakers. But first, I would go to Iype. There are many questions, but I should read it. First question is, how about Iype? Can you hear me? Sorry, Iype, can you hear me?
I am here.
Oh, okay. Thank you. Is there necessary to put the drain after cisternostomy? This is the first question. The second question is for severe head injury case, in your experience, is there any limitation for cisternostomy despite the anatomical and clinical condition of the patient? The third question is about do still necessary sometimes after cisternostomy that we have to make a decompressive craniectomy because of some clinical condition. Okay, please, Iype.
Yeah, see, first answer to the first question, always put in a drain. It's very, very important. So we had, for the first few years, we put the drain. Then for 1 year, because we had severe ventriculitis and infection, we stopped the drain, and then we started putting the drain again, because we saw that without the drain, there can be rebounded. So the thing about the drain is, you need to drain, you need to keep the bag, the EVD bag. So what we put in as a drain is a number 8 feeding tube. So we put in the number 8 feeding tube, connect it to an EVD bag, and keep the bag at the bed level for the first day. And once that is done, about in 24 hours, the blood starts clearing. And if it's clear CSF, once the CSF clears, you can put this bag at 15 centimeter height. Very important, because if you keep it low, then there can be over drainage, and this is equally bad. So we have learned our lessons. So drain, remember about the drain, put the drain, keep it at bed level for 24 hours till the next day morning. And if it is clearing, then you can take the bag and put it at 15, put it at 15 centimeters. Second, any head injury without infarction. So how do you figure out infarction? If there is clear signs of radiological infarction, if the patient has been very low GCSs, M2 with both pupils dilated, low GCS, pupils bad, radiological signs of infarction. This is the only time then you need to convert it into a DC, or you think that maybe cisternostomy may not be good. But then even if you convert it into DC, these patients are not going to do very well. So infarction is the only contraindication to cisternostomy at the moment right now, because well, of course, diffuse brain swelling, severe diffuse brain swelling, you saw the videos, how tough it is going to be. So, but then if you're able to get into the cisterns and evacuate some CSF or evacuate some blood, you're going to be all right. So I think I've answered questions. You are muted, you are muted, you are muted.
Okay, sorry. Yes, there are still many questions for you, Iype, but I will move to Dr. Ahmad Faried first. Question about bifrontal craniectomy, Dr. Faried. What do you think to treat severe edema after head injury? Is there still any role, or about your experience, please?
Yeah, of course. We still usually do the bifrontal craniectomy in our center, but we have to make sure that we have to separate the frontal cistern and go to separate the valves. Otherwise, it's too tight and it will make more worse than before. So we still perform that in our center.
Okay, thank you.
May I have one question for Professor Cherian?
Okay, please.
Yes,
Professor.
please.
Okay, so my question is, do you have an animal model for us, for young neurosurgeon, to practice, at least experience how to go deep into the tight brain? I mean, if you can perform that, then it will bring us more confidence into the real practice.
Yeah. So I would recommend that the boys who want to do cisternostomy should come with me, because I'm moving to India right now. So that I'm moving to a center where we have at least 4 or 5 traumas every day getting operated. So I would like to, the boys who would want to do cisternostomy should come with me, will be my guests, like Rakesh or Ido or people like that. I mean, they should come with me. They should stay with me, and I'll make them operate. I'll make them to do these cisternostomies. But they should have some basic microscopic experience, like assisting under, they should know how to assist under the microscope. So if they can do that, then I'll train them. I promise you that I will train them, and I'll make sure they can start cisternostomies later on. So this is what I can do. I mean, we have looked at all animal models with the Russian neurosurgeons, but this doesn't work. This doesn't just translate into clinical experience. So the best is to come to a center where, you can go to Jeti Parthiban Center in South India, you could go to Wang Center in China, you could go to Royal Center in Lausanne, you could go to the Iype Center in Brazil. So any of these, Samer Center in Iraq, all these centers are doing cisternostomy. So even Rakesh and the Malaysian guys have started doing cisternostomies as well. So all these centers are doing it. So if you would like to come, please, I mean, you're very welcome. And maybe you need to stay for a couple of months, maybe 3 months. And then after that, you go back to your Indonesia, center in Indonesia, start doing cisternostomies.
Thank you very much, Professor.
Okay, thank you, Iype. And a question to Dr. Tedy. Ask about the result of DC for TBI with GCS below 8. So what do you think, Dr. Tedy?
Yes, thank you, Dr. Asra. So yes, I think we have make the critical KGS below 5, Dr. Asra, that you give me the idea at the time. So yes, it is that we know that the result for KGS, critical KGS point, that we make a decompressive craniectomy, the result is not good enough. Not good enough because our research is very, very limited. And we didn't have maybe the neurosurgical intensive care. We have to make is more good again, maybe in the future. And the result only 16.2% survive.
Yeah.
And it is very low, but this is our policy in our center at that time, that we must do the decompressive craniectomy, even the critical is the KJS is very critical below 5. Why? Because this is our policy, and I told in the consensus that this is a local area policy because of the surgeon. I think that's Dr. Asra.
Okay, thank you, Dr. Tedy. And I will go back to Iype again. There is two questions for you. It's very interesting question. How you're dealing about still the controversy of this kind of treatment? Many journals said, this your procedure is, still lack of evidence and anything else. This is the first question. And the second question is about the future of cisternostomy. Is there any possibility to, the less invasive technique with guidance of OSG or landmark or something else? And also, could it be in the future there is a strict indication so you can choose this is useful for cisternostomy and this is could be more useful with DC? Okay, 3 questions, please. Iype.
I couldn't hear that because I was disconnected, Asra.
Oh, okay. Now you can hear me?
Yeah, I can hear you.
Okay. First question is how you dealing about still, the controversy of this kind of treatment. Is many journal and many experts say it's lack of evidence. This is the first question. And the second question is about the future of this cisternostomy technique.
Yeah.
Using the more or less invasive USG or many tools. And second is about the indication. The future, is there any indication that this kind of treatment is useful with cisternostomy? And then the other is more quite benefit with DC. Please.
Okay. Yeah. So the first question I would tell you, Asra, you know me for many years now.
Yes.
And, the controversy was much before. Many years back, the controversy was much before. Only I was doing it and nobody else was. Today, in the world, there are so many people doing it. And the only guys creating controversies are people who doesn't want to do it, as simple as that. So, I mean, it doesn't matter. I mean, those who doesn't want to do it will die a natural, death. That is all I can say. Just like DZ would come to an end. Just like DZ would come to an end. The guys who don't want to do cisternostomy will be forgotten. The future. Can you hear me?
Yes, we can hear you now. Yes, please continue. Okay.
Yeah, so the controversy, as far as the controversy is concerned, it's much less now because the whole world has started doing it. And the only guys who don't want to do it are those guys, those big trauma neurosurgeons who are data collectors and who will never want to learn microneurosurgery. Now, the future is cisternostomy because all the young residents, they want to learn microneurosurgery, and this definitely would be the future. There's no question about it. And you want to combine it, the third question about combining it with DZ? No, I mean, in my initial phase, I used to combine it with DZ. This is how maybe you should start too.
Yes.
But After about 284 cases, we stopped doing that. We just did only cisternostomy. Now, most of our cases, even our residents or our consultants don't combine, we just do cisternostomy. But that's a learning curve. So if you want to shift from today to cisternostomy, the best thing is to probably start combining first. And then once you are confident that the brain is quite lax, then you can start putting the bone plug back.
Okay, thank you. So we have two last questions for the Tedy, and maybe the last question will be to Iype. Dr. Tedy, this is a question for you. Can we predict to do DC or not based on CT scan pre-op, or we have to see intraoperative brain edema or not? Dr. Tedy, please.
Yes, Dr. Asra.
Yeah, okay, please.
When we are in the consensus at the Cambridge in the second day, someone presented about this, and someone is asking about, can we predict about this? Can we predict from the CT scan or the other? Yes, we can see in the consensus of the TPI at the time, it is said that when we want to make decision for decompressive craniectomy, we must see the clinical of the neurological clinic from the patient. We must see the CT scan, and we must see the ICP monitor.
Yes.
And for that, we can predict about that. When we see the CT scan is very diffuse, we have a diffuse brain edema, the ICP is very high, or after that, in the duration of operation, during the op, we must check if the brain is relaxed or swelling. But still, the decision for the operator in the operating room is very, very the one who must make the decision at the time. So I think duration during the op is very, very important. Yes, we can predict, Dr. Asra. Thank you.
Okay, thank you, Dr. Tedy. Because Professor Cherian is have to go to the operating room and emergency case, so he left earlier. But I think I'm going to say that thank you very much for all the participants and all the speaker. I think the topic is very important for us. I hope it could be benefit to our neurosurgical practice. And once again, thank you very much for your participation. I hope this webinar will be benefit for our neurosurgical practice, daily practice. Okay, thank you very much and goodbye. Selamat malam.
Thank you very much, Dr. Asra.
Yes.